Hello, everyone. Thank you so much for this meeting. We have wonderful, very famous speakers. And tonight, today, wherever you are, we will talk about keratoconus. As much as possible, we will not take your valuable time, and we will talk very important approach. I believe this will be featured in keratoconus treatment. In Oracle meeting. First, our speakers, immediately I will move next speaker because we want to use our time very effectively. Soosan Jacob is very valuable speaker, innovator, and this is from her first idea from her, allograft corneal in ring implantation. And I believe in the world this will be very popular, this will be featured. And I'm really excited. She accepted to join us. I'm really looking forward to listen her talk. Yes, Soosan, we can listen you. Thank you so much again to join us.
Thank you so much again, Aylin and Christian and the entire Oracle's team for having invited me here. And again, for the interest of time, I will start off with my talk. My talk is on corneal allogenic intrastromal ring segments, or CAIRS, and this is the acronym that I had coined for this way back in 2015 when I just started with this treatment. And at the outset, I must also say that I do have a patent pending for special refines devices and processes, as well as for modified CAIRS segments. So we all know that the current treatment of keratoconus is at a very good stage indeed, and we can halt progression using corneal cross-linking. But the problem with corneal cross-linking is that by itself, it has a limited role in regularizing corneal topography. And for this reason, actually intracorneal ring segments, or ICRS, in the form of various commercially available synthetic segments such as intact Kera rings, Ferrara rings, Mayo rings, and so on and so forth, have been available for long and have been used very effectively by corneal surgeons since long. However, one of the problems with all of these synthetic segments is the very fact that it's synthetic, and this can result in complications in the cornea because synthetic segments are not really ideal for the cornea. So these are some of the complications that I myself have personally faced in my series of ICRS, and you can see they range from intrusions, extrusions, corneal melts, necrosis, antistromal necrosis, and so on and so forth, infectious keratitis, and so on and so forth. And here is an image courtesy Gillian Siu from Hong Kong, where the ICRS has actually intruded into the anterior chamber and caused high drops and subsequent scarring in a patient. So you can have a lot of problems with these synthetic ICRS, and that was when I had this idea about why not use allogenic implants. And as I said, I had started this in 2015. We published our first series in, of course, lots of non-peer-reviewed places and sites, but in JRS was our first peer-reviewed publication. And as I said, the acronym stands for corneal allogenic intrastromal ring segments, or CAIRS. Allogenic, as it implies clearly, can be of any source. It could be fresh donor stroma, preserved donor stroma, processed donor stroma, or basically any source of allogenic tissue can be used, and that's what CAIRS stands for. And I'm sure Aylin will also be showing in her talk subsequently. So here is a technique as we do it, but as I said, it could be done with other sources of allogenic tissue. This is a special double-bladed refine that I have designed, and you can actually use it to punch out these allogenic tissues. So here is, if you're using donor corneoscleral rim for creating these segments, you remove the epithelium and endothelium, and again use this special double-bladed refine, center it on the donor cornea, and punch after having removed the epithelium and endothelium. So what you essentially have is a ring of stromal tissue, which you can then cut, and you can insert it into femtosecond laser dissected channels in the patient's eye. Of course, you can also do this using a manual dissection for the channels, and then subsequently implanting the segments in. So as you see, the segments do slide in pretty easily. It's, when you first think about this, you think about corneal tissue and compare it with how you implant synthetic segments, and you often wonder, how do you actually get these segments to go in? But as I showed you, you can actually get them to go in pretty easily. So here's an example of manual dissection, and This is, of course, this can be done using the prolate system, the suction refine, or you could just do it using manual markings and using a manual dissector, and then getting that groove in place, the channel in place, followed by insertion of the segment. You could color the refine segments just so that they're better visible, as a lot of publications from other authors have also started coming on CAIRS, and a lot of different techniques have now been published with, staining the CAIRS or dehydrating the CAIRS segments and implanting, and so on and so forth. So, I'm sorry. Here's a post-operative appearance of what a classical segment would look like, the CAIRS segment. And you can see that I implanted at around 50% depth of the cornea, and you can see very quiet segments here on either side of the visual axis. And you could, have two segments which are placed on either side, or you could have a single long segment, or you could have one segment which is just below the visual axis. So you can actually decide what kind of segment you want to place and how thick it is going to be, and the optic zone, and all these things depending on the type of topography or the type of keratoconus you want to treat. So there's a diffuse slit view of the impatient, and again, you can see a very, very good and quite well-placed segment with 50% thickness, as I'm showing here in this slide. The anti-segment OCT images are seen here, and you can see that you can see very well-placed quiet segments in the mid-stroma. And again, various different arc lengths seen here, which is really difficult to do with the synthetic segments, because then you need to have a wide range of, these segments with you in your OR. And having to have a large inventory, which is really not necessary when you're doing CAIRS, because you can actually cut them into shape right there and size right there in your theater. Complications, as I said, it's not just those advantages that you have of avoiding complications associated with synthetic segments, but also the fact that you can actually increase the range of keratoconus in which you can implant these segments. So we know that synthetic segments cannot be implanted in very thin corneas or very steep corneas more than 58 diopters, and that you do have limited effect if you go very deep. But here you can see that you can actually implant CAIRS in very advanced keratoconuses and also in the very early keratoconuses. So an entire range of keratoconus can be treated with CAIRS. You can have an arc length, arc segment, or all the way up to 360 degrees, or of any arc length actually if you want. So you can customize it quite well, and you can treat very advanced keratoconus. You can see here about 30-34 diopters of flattening gotten very advanced keratoconus, bringing the topographic range to almost normal in this post-operative appearance. And the shine fluke comparison images, which shows a lot of flattening in the patient's conical protrusion of the cornea, which all goes to show the effect you can have. Again, a very thin case which had just 230 microns of residual stroma, where we did a combined contact lens assisted corneal cross-linking, which is again a technique which I had started in 2012, combined with, in this case, epithelial island cross-linking and CAIRS, and we got it was an asymmetric keratoconus, so we implanted only one segment, and we got a very good result in this patient. Very happy to say that now CAIRS is being done in many places, many countries all over the world, including India, USA, Canada, and so many island right here from Turkey, Israel, Lebanon, Dominican Republic, Germany, Ireland, and many other places have started CAIRS. And it's not just the surgeons, but also patients who've heard about this through word of mouth and who actually come looking for this treatment. Here's a patient who had a synthetic segment melt, which has been treated with CAIRS implantation. So that has been removed and replaced with CAIRS. Very simple surgical procedure. Actually, you take the segment out and you put in the CAIRS segment, and you kind of put bridging sutures and anchoring sutures on either side, and you can go ahead and treat this complication of synthetic segment. And here are a few patients, and we've also published a series on this now with my friend Shri Awad. Some topographies here, you can see the regularization which you've got with CAIRS, where it's not just flattening of the steep axis, but also steepening of the flat axis, so which leads to an overall regularization and an improvement in the spherocylindrical error, as you can see in this patient, from -2, that's my time up, from -2 7 cylinder to about -2.5 cylinder. And again, you can vary the amount of effect you get by varying the thickness of the segment that you're implanting. Just a comparison to show how CAIRS is given advantage on a lot of flattening in the right eye of this patient, whereas the left eye had no difference, having done just cross-linking alone, showing how CAIRS can really improve topography. You can have double segment CAIRS, asymmetric CAIRS, single segment CAIRS, and so on and so forth. and really has huge advantages over talc. And with that, I'll come to my last slide. The advantages are not just that it doesn't have the disadvantages of synthetic, but also the fact that it's very biocompatible, has good corneal integration, less complications, and is adjustable, reversible with very low level of rejection. That I'll come to the end of my presentation. Thank you so much, everybody.
Thank you, Soosan. Thank you. Really, you were our guest, one of our first Oracle meeting, and each time when I listen to your talk, I really enjoy. I really smiling and appreciated you a lot. So I hope. I think this is history, and every time I will think about your wonderful innovation, each case in each keratoconus case. Now I don't want to give break quickly. I want to move my talk, and then end of speakers talks we will discuss. Now I am sharing my screen. I will talk about KeraNatural, which is the name of product. Actually, KeraNatural is not a technique. This is just name of product. Already Soosan explained. This is allograft corneal inlay. But this is just alternative to use corneal inlay. I just wanted to remind, and this Joseph Collin is my mentor, and first intacs performed by Joseph Collin in 1997. And after this period, I performed more than 1,000 eyes, keratoconic eyes, intracorneal ring. It is really working, but unfortunately, long term, I cannot promise any patient. Just postpone keratoplasty is the best benefit after PMMA intracorneal rings. And after allograft corneal inlay with Soosan Jacob, I believe for future, when we implant intracorneal allograft rings, it will be remain and may change keratoplasty indication for future in keratoconic eyes. Today, we perform almost 85 eyes and 2 years follow-up maximum. So actually, Allotex and KeraNaturals are company names, and they are sister or brother, whatever tell. Only tested eye bank cornea, and this eye bank cornea can be cut, can be shaped, and can be packaged for years, 2 years follow-up, 2 years shelf life. Sorry, I'm very sorry. So from one cornea, we can produce 4, 5, maybe 6 corneal ring, whatever depends of wide of corneal ring. And we can use one cornea to for 5 eyes, and it is very useful, and to also to increase keratoplasty for other indications, not for keratoconus, maybe for urgent cases to perform keratoplasty. This treatment is more useful for keratoconus patients. I focus more nomogram, and I wanted to also increase clinical series, effectivity, safety, long-term results. This is Soosan method. Already she explained wonderful. And I wanted to start our first case. This first case is a 34 years old male, and he had vision loss in left eye and uncorrected 0.4, uncorrected 0.1, best corrected 0.4. As you see here, there is asymmetric topography. And we wanted to perform intracorneal ring, but we had no idea which nomogram we have to use, because my experience is usually steep incision axe and 2 intracorneal ring opposite each other. It was like that, my experience. And first I tried this, and we observed that it is really not good topographic change. This is preoperative, and left part after operation, irregular cornea, and there was a vision loss. I was feeling very bad, and I couldn't explain patients what happens. But good part of this treatment, this is reversible, rotation is possible, and we can change our surgical plan. And second step, I performed one segment. I wanted to change this surgical plan and to rotate one intracorneal ring to the down according to cone location. As you see here, this is one of advantage. You can remove intracorneal ring, and also you can pull intracorneal ring into the channel, and you can create different effects. This is possible, and this makes me as a surgeon really more comfortable to manage patients. So I wanted to pull this segment to the down according to cone location. And then after this location change, as you see, it is very easy, can be rotated after 6 months, and cornea is very clear also. After operation, second operation, we implanted lens in left part, more regular cornea. This is same eye. This is preoperative before first operation, and left part after second operation. Here is more clear. Left part baseline, there is vision loss, and when we make a mistake, as you see, when we create incision according to steep ax and 2 implants, there is more irregular cornea and vision loss. And when we create enhancement rotation, and when we remove one segment out, there is more regular cornea. And this surgery, first case, encouraged us, and we understood this is manageable, adjustable, and removable, and this makes us really very happy. This is another case also Soosan showed us in OCT. This is wonderful fusiform shape and very thin superficial area, and very regular postoperative topography. And about nomogram, this is different than PMMA. Soosan already summarized. We choose 35% tunnel depth, and tunnel width is different than PMMA also. Sometimes 7.5, sometimes larger channels we are choosing if we want less effects. This is comparison of PMMA and allograft corneal inlay. Also, this is another advantage. We can split intracorneal ring if we want less effect. If it is mild keratoconus, we can split, we can use half thickness. Sometimes when there is a less refraction, I am doing this. And this is our surgery technique. And this is separator, modified separator. We are separating after femtosecond laser cut, and I am cutting other side to pull intraocular segments up. And then we are implanting segment. This is superficial channel, more superficial, and a larger channel than PMMA, and very easily going inside the channel. In this case, we don't need to pull channel other side, but some cases we need to pull other side. As you see here, we open a small incision. We can pull to prevent folds. So when we look post-operatively, some cases are really very regular cornea. Each cases are not symmetric like that, but most of cases this treatment was very beneficial for them. Flattening effect. This is our 6 months follow-up, 20 cases, but we will publish very soon our larger series with longer follow-up. But generally, Q value reduced, uncorrected and best corrected visual acuity increased. And this is really very prominent, statistically significant change. And clinically, I don't remember now, almost none of case didn't lose vision loss. Some cases had affect one line, some cases even could see 20/20, but all cases we observed increased visual acuity. This is very important. Some of them are using glasses, some of them are using contact lenses. This is our purpose, of course, to create more regular cornea. This is another case. And here there is a fusiform shaped intraocular ring, and this may prevent visual some disturbances, optic disturbances like halo glare we had experienced in the past with PMMA more, and we don't expect extrusion with this elastic soft tissue. And this is first day. We also measured OCT follow-up. First day, we can see a superior part of tunnel thin. We created 200 microns tunnel depth. And within time, we can observe thinner 130 microns thin. This is really, we didn't create a tunnel like that, but there is also little bit stretching superior part of tunnel. This is first month, and when we look third month, now epithelial remodeling we can observe, and there is a little bit thickening, because this is not thickening, maybe this is, there is a large channel and this tissue going sides and creating thinning and less stretching than first day. I hope I could explain better way. I want to tell everything quickly. There is a time limitation. So now 6 months, this follow-up show us first day, there are some spaces near the channel. As you see, there are spaces. And during follow-up, as you see here, there is no spaces almost. And this allograft tissue here thicker, and 6 months later thinner, and accordingly remodeling of epithelium, stroma, superior part and inferior part. This is our message. Next slide. As a conclusion, allograft corneal ring chairs, we like chairs terminology, but our patients didn't understand allograft, intracorneal ring. So we are trying to explain them more organic and biologic way. Already Soosan explains, this is reversible. This makes us very happy, easy, very short surgery time when we compare keratoplasty. This is, our experience showed us this is safe. And at the moment, no extrusion risk. We didn't follow up something like that. And it is effective for refractive correction, optically, topographically, and refraction, contact lens or glasses tolerance increased. And larger clinical studies are needed to demonstrate the effectiveness and safety with longer term follow-up. So my presentation finished. Now I want to move Cynthia presentation, and then we will discuss.
I want to thank Aylin for inviting me to speak at this meeting on the biomechanics of keratoconus. These are my disclosures. And the hypothesis that was actually first proposed in 2007, actually in one of Aylin's books, was that in keratoconus, curvature, thickness, and elevation changes are secondary symptoms of keratoconus, and that the primary corneal alteration is focal biomechanical weakening. And if you can think about this focal weakening, that means one area of the cornea becomes weak. That immediately redistributes the stress. As the stress is redistributed, there is less resistance to deformation, so it thins, which redistributes the stress. In compensation, there's a little focal increase in curvature, which also redistributes the stress, and then this becomes a cycle of biomechanical decompensation. If you look in the literature, the early literature in the 70s and 80s, there was this concept that keratoconus was globally weak. And that's because what happened is the tissue was actually tested using something called uniaxial testing. So there was no effort made to look at asymmetry. If there was a weak area in this piece of tissue, the entire piece of tissue measured as weak. But if we think about this as a focal reduction, so we have this one area of the cornea that becomes weak. Well, the cornea is loaded by the intraocular pressure, which means this red area is less resistant to deformation, so it stretches. As it stretches, it becomes thin, and as it becomes thin in a compensatory manner, the cornea bulges there, all due to this initial focal weakening. Since that time, actually in 2015, it was demonstrated by Giuliano Scarcelli that in vivo measurements of keratoconus using Bruin microscopy, that this focal weakness was actually present in vivo. So this was the first time that in vivo measurements were made that documented this focal weakening. So we can conclude that not only is there asymmetry of curvature and pachymetry, but also of properties. And in a suspect cornea, the likely initial change is focal biomechanical weakening, which means the optimal detection scheme would be based on asymmetry of properties. Now, I want to talk more specifically and share some results that we're going to be presenting at ARVO in a couple of weeks. But if we think of the stress, the hoop stress on the cornea, where this is stress right here, this little sigma, it's pressure times radius of curvature divided by 2 times the thickness. So what does that mean in terms of where is stress highest? So highest stress is where the cornea is thinner, and that's because it's in the denominator. So the smaller this is, the larger the ratio. But it's also where it's flatter. And this is something that I don't think is well recognized. But if we look at the radius of curvature, what makes it larger is a flatter area. So high stress is caused by thin, flat areas. And you can look at this blown up balloon to see that the pressure is all over uniform. But where is the wall stress lowest? And it's right here where the curvature is greatest. So if we want to look at what is the corneal contribution to stress, we need to remove the influence of IOP, which always determines the maximum stress if we're comparing 2 corneas or even before and after a procedure. So I call this corneal contribution to stress, which is just radius of curvature over 2 times the thickness. And it's the same thing as with the hoop stress, except that we're not using the confounding influence of IOP that makes comparisons difficult. So we did a prospective observational studies. We had 66 eyes of 40 subjects diagnosed with keratoconus and 310 eyes of 155 normal subjects. We had Pentacan tomography, and then we used custom software to locate the maximum and minimum values. And this is in the literature, cone location and magnitude index. And what it does is it searches the cornea for this 2 millimeter diameter region of greatest curvature. But we can also tune that algorithm to look for the minimum, the lowest value. And we can do that to look for the location of the thinnest curvature. So what we did is in our normal eyes, we used the highest value to look for the highest value of curvature and the minimum algorithm to look for the lowest value of pachymetry. And then we also did that on the stress map. This is the corneal contribution to stress. And we find the highest stress is in this location and the lowest stress is in this location. Red is high, blue is low. And what we find in normals is this highest stress area coincides where the curvature is greatest, but that doesn't make sense based on what we know of stress, but it's also where the thickness is lowest, and that does make sense. So we know that in normal eyes, the stress distribution is dominated actually by thickness, which seems very intuitive. However, if we look at the 57 keratoconus eyes with central curvature, and this is an average of all 57 eyes, we can see, again, low is blue, high is red. So we see the area of highest curvature on the tangential map is right here, but that also coincides with the area of thinnest pachymetry. Now, again, with stress, thinnest pachymetry would be the area of high stress, except let's look, it's not high, it's low. So in keratoconus, there's a compensation where the stress distribution is now determined by curvature, not thickness. So when you change the curvature immediately, you change their stress distribution. And an important factor of this is in our population, we looked at the delta corneal contribution to stress. That is the maximum minus the minimum. So on a single cornea, we're looking at this value minus this value. And what we find, if we regress that against, this is the magnitude of the area of highest curvature. So you can think about this as a measure of the severity of the keratoconus. We can see a very strong linear relationship with the greater the area of curvature, the larger the difference between the high and the low. And in fact, that explains almost 60% of the variability. So in conclusion, in normalized, corneal stress distribution is driven by thickness, but in keratoconic eyes, it's driven by curvature. So if you change the curvature pattern, you change the entire biomechanical environment, and that will influence what happens to the corneal shape over time. The difference between the high and the low is significantly associated with this maximum curvature, and therefore may be a good predictor of progression and potentially of diagnosis. Thank you.
Thank you so much, Cynthia. Now we have 12 minutes to discuss, and we have one question. Are you cross-linking with riboflavin and dextran solution? And if you are using dextran, does the thickness change considerably with time hydration? James Garman asked question. This question is to, I think, Soosan, because we saw also riboflavin. How is your approach, Soosan?
Yeah, I think, thank you, James, for this question. And this initial question was also about whether we cross-link, and if so, how. Yes, I answered the first part of the question. I've done it both ways, cross-link the segments and then put it in, or cross-link it later, along with the corneal cross-linking. That is, most of the times I just put the segment in non-cross-linked and then cross-link it together along with the cross-linking that I'm doing anyway for the the CAIRS, for the cornea, the keratoconic cornea. That generally seems to work well enough. What I use is dextran with riboflavin. The follow-up that we've had of the anti-segment OCTs really does not show much of shrinkage within the cornea. And I think this is also what some of the other people who are doing additional technologies for keratoconus have also found, that once you put it within the stroma, it's really, the change is not too much. And we don't know why that is so, because we know that when you put in DZEC, it does change, it thins out over time. Some of the same doesn't seem to happen here. And possibly that's because of the intrastromal location. It's not in contact with the aqueous, or as in a dial lenticule, when you put a dial, it again thins out with time. Maybe that's because it's not in contact with the atmosphere. It's right, the intrastromal secluded from everything else. Maybe that is the reason, or maybe it's possibly just because you're cross-linking also at the same time. So ASOC studies have really not shown too much of thinning of the segment over time. Though I have not analyzed all my data so far, so I do have to do that. But an initial analysis seems to suggest that.
Thank you so much, Soosan. So also I would like to ask Cynthia. Cynthia Roberts is very valuable for me, very important for my career. I wanted to introduce also this way. I'm sorry, time limitation makes me excited. So what do you think, Cynthia, about cross-linking and allograft implantation? What is your idea? What do you think about that?
Well, I think that what you presented, Aylin, that implant actually thins and fills up the channel over time, is a really important part of the implant biomechanically integrating with the cornea, something that PMMA implant could never do because the properties are so different. And I think if you cross-link it before you put it in, I think I heard Soosan say that doesn't happen, that the implant doesn't thin. Is that correct, Soosan? Is that what you said?
Yeah. So what we found is that there is a thinning that happens immediately post-operatively. That's obviously because of the post-operative edema that thins out, and that happens in the initial period. But over the years, let's say from the first year to the second year, third year, fourth year, and fifth year, I don't find much change between the years.
If it's cross-linked?
No, either way.
So what I would say is, I don't think that's from the edema. I think that's because the implant is susceptible to the forces in the cornea. You have tension in the lamellae above the implant, and you have tension in the lamellae below the implant, and then you have this soft multi-layered implant in there. And I think it responds to the forces in the cornea. So I don't think that the thinning of the implant is due to edema. I think that the implant is incorporating itself into the biomechanical environment of the cornea. I don't know what happens with cross-linking, and I think it might be important to look at what happens over time from purely an academic perspective, but maybe even in terms of outcomes without cross-linking, because what this does is actually change the stress distribution immediately, because you immediately change the curvature. And what cross-linking does is change the properties. So you're doing two different things at the same time. And if you want to be able to look at what contribution to the progressive change in shape is due to the increasing the thickness and decreasing the curvature, if you cross-link that, you complicate it, because I don't know if the cross-linking occurs in the implant at the same amount as it does with the intact lamellae. I don't know if we know that yet, but I do know if you want to separate and look at the effects of simply the implant and then the implant with cross-linking, you would need to separate the procedures just to find out what the contribution of each is.
Mm-hmm. Supi, also you made your first case with
Yes.
allograft inlay, and do you have any question?
Well, I would like to thank all of you three speakers for your wonderful talks and for pioneering this whole new field in ophthalmology. I think this is going to be refractive surgery for those who need it the most, for keratoconic patients. And up to now, keratoconus eyes were not suitable for refractive surgery. They were a no-go zone. And I think you are pioneering a new approach. You are addressing an unmet need, because these patients cannot wear contact lenses typically, because most of them have allergies or are intolerant to contact lenses. So I think this is a very valuable approach. Cynthia, let me start with you. What would you propose as a staged procedure? Cross-linking first, or implantation of a ring segment first? And
so what we know in keratoconus is that the area of the cone has very disorganized lamellar structure, and that has shown by Keith Meek's work. So I don't even know if there's uniform cross-linking between the normal part of the cornea and the area of the cone. What's been shown, actually, Giuliano Scarcelli showed, if you take a keratoconic button and you look at the weak area, which is substantially weaker, in the 180 degrees away on the other side of that button, it's not differentiable from a normal cornea. So that's how we know you've got this focal weakening. What I don't know is if the entire cornea cross-links to the same level. So I think that the first study that I would recommend is the implant, and then wait. I think Aylin told me yesterday she's been waiting 6 months to cross-link. And I think that will allow us to evaluate what change happens from the implant alone and how much it integrates into that channel. And the advantage of that, if you made a tighter channel, I think you might reduce the amount of integration. So I think having a little bit of a wider channel, that I would think, I'm not a surgeon, I think that would allow better manipulation, but it also allows that implant to fill in the spaces and integrate with that cornea. And I think that with such a new procedure like this, it would be really important to find out the contribution of that first.
Mm-hmm. If I may, I have several questions. What would be the best thickness based on your surgical experience and based on your theoretical approach? What is the best tunnel depth? Because on the OCTs and on my limited experience, the posterior cornea is more bulging than the anterior cornea. So what is the best thickness and of the implant, and what is the depth of the tunnel?
I'll let Aylin answer the depth of the tunnel, and then I can explain it.
Actually, we discussed with Supi also about that. In our first cases, we implanted very deep, and we understood there is less effect. And we removed this intracorneal rings because it is, first of all, it was narrow and deep channel like PMMA, and it was not easy to implant, and effectivity was not like that. And I planned to make superficially because I didn't want to create trauma, and I just want to little bit touch the patients. But we were very surprised. We understood very much posterior bulging, posterior part of cornea, and there is a more than my expectation. There was a wonderful effect, even 200 micron step, around 30% of 30% of depth of cornea, and we created 3.5 millimeter wide channel. So this is our experience. So I think Supi wanted to also learn to discuss superficial replacement and posterior replacement. Also, this is still question. And this is my experience, but maybe biomechanically you may have comments.
So what we know is the anterior region of the cornea is strongest. And the reason it's strongest is because it has the most cross-linking. So if you put it in the posterior region, the reason that was done with PMMA rings is because if they're too superficial, they can extrude. And as you pointed out, that's really not really a complication in this. So when you put it in the lower regions, it doesn't hold it as tight. When you put it in the anterior regions that are stronger, that have more cross-linking, it will hold it in there tighter, and it will allow this biomechanical integration, which has a greater effect. So I think even the rings would work better if they were more superficial, but you can't do that because then they'll extrude. So I think that you can take advantage of the greater biomechanical effect with a more superficial implant without worrying about the complication.
So what is the safety margin that we have now with the allogenic implants instead of the PMMA rings?
Safety margins, you ask Cynthia or Susan?
All of you three.
Safety margin.
I mean, how superficial can we go now? Because the reason for going deep with the PMMA rings was fear of extrusion. Now we don't hear extrusion. Susan.
I can answer that question. So, we have done cases where we've had melts of intacts or melts secondary to intacts, where we've taken it out and we've pushed in the CAIRS segments in place. So what happens is you have an area where the CAIRS are extending into the tunnels from which, the intacts have been removed on either side, but there's also an area where it's completely exposed to the atmosphere. It's right on top. And we found that both areas integrate well. This is, when you do a DALC, you're having the cornea sit right on top of the bed. And it's the same thing. As long as you have corneal tissue, it doesn't matter. It just integrates well into the rest. What you have to be careful about when you do that is that you don't have epithelial ingrowth between any gaps. So for that, you need to have a tight fitting CAIRS. And when I did it, I also put glue at the edges so that you don't have any gaps through which epithelium can grow in, and then it integrates beautifully. You would want to put some sutures, as I showed in the video, actually, some sutures just to hold it there in place initial period so that it doesn't pop out or it doesn't kind of, just bulge out in the center part where it's not covered by overlying lamellae of the patient. But once it integrates, it just stays there. So the answer to that question is you don't have to have lamellae on top throughout. You have to have enough to hold it in place. That's all there is to it.
So, and my comment on that was, I think, Susan, you were responding to a complication from the intacts. I think if you're doing a primary case, not responding to a corneal melt, if you have some lamellar over top, obviously that would prevent any epithelial ingrowth, but in addition, it would allow greater force on the implant. So I would say the more tissue you have above it, the more you're going to biomechanically integrate it. The less tissue, the less biomechanical integration, but none of those are safety. So I think what Susan has let you know is that safety is less of a concern with the implant.
Last question. The implanted ring thickness between two surgeons look very different. We may be increasing the effect of the ring by using full thickness cornea. but can we also increase the stress on the cornea? I'm especially curious about Cynthia's opinion.
What we want is regularizing the stress on the cornea. We want to reduce the asymmetry of the stress on the cornea, as opposed, so you want to increase it where it's low and decrease it where it's high, because that asymmetry is what drives progression. So we want to do both, as I think probably Soosan and Aylin both talked about. You increase the flat and decrease the steep, because the entire cornea responds to this change in its structure and its stress distribution. We do change the stress distribution in the cornea with the implant, but I'm trying to, can we increase the effectiveness of the ring by using a full thickness cornea? I don't know. I think a full thickness cornea would be too much, because that would be too much, because it might actually drive additional asymmetry for a different reason. So you don't want to end up with an asymmetric cornea. You want to end up with a symmetric cornea, and you have to take into account, how much that implant will decrease in thickness, and it might be you could customize it by looking at the overall thickness and curvature distribution, and maybe simulate with a model what happens with different thickness implants to determine what would be the optimal outcome. Mm-hmm. Each cornea is going to be different. Each keratoconus is different. So I don't know if there's a real uniform rule for keratoconus.
Mm-hmm. Cynthia, that actually raises an interesting question here. You just said customization. So you said, and I think we all agree on, every cornea to start off of a patient will be different. So now the surgeon has to make a decision of, where to put it, what depth you have to put it, and what is the size of the implant. So do you see that biomechanical simulation will help us to come up with nomograms?
Absolutely. There's no question in my mind. And this, I know surgeons call it a refractive procedure, but I look on it as a biomechanical procedure. You're regularizing the stress distribution. And therefore, if that's your target, if your target is to reduce this asymmetry, biomechanical simulation will be incredibly helpful to actually accomplish that, because you can build patient-specific models. And I know even with rings, with cross-linking, there's a lot of surgeons around the world that think their nomogram works the best, and yet many of the nomograms are different. And the reason they're different is because the vision in keratoconus is so poor to start with. You can do almost anything to regularize it slightly and improve vision, but it doesn't tell you what's optimal. It doesn't tell you what's the optimal improvement. And to look at an optimal improvement, we need a biomechanical simulation of that cornea that would allow us to determine what can we do to give the optimal post-op stress distribution, and that will allow the greatest stability.
Yeah. I also have a question to Aylin and to Soosan on both sides. You both haven't really spoke about what is the limit of this treatment? How far can you go on a keratoconus? This is one question, and associated with that is, I haven't heard anything about complications. So is there tissue rejection, or what complications can we expect? So Sophie just started, probably he has concerns about what can we expect in terms of complications here with the tissue. Maybe Soosan, and then maybe Aylin.
Mm-hmm. Soosan, I can start if you want, or actually about keratoconus, can be early keratoconus or late stage keratoconus. If we want to increase effectivity of ring, we can change allograft corneal ring thickness or diameter to reduce or increase. If we want higher effect for severe keratoconus patients and higher refraction, we can use thicker segment and smaller size diameter corneal channel. I wouldn't change depth of tunnel at the moment. This is my experience. I don't know in the future. And if I want less effect for early keratoconic case, if they cannot use contact lens or glasses to create regularization of cornea, I will use thinner segment, thinner allograft. I showed in video, I can split easily. And I would use larger diameter of intercorneal channel. So what I would expect as a complication, actually intraoperatively, little bit manipulation, but it looks like not difficult. And during follow-up, I don't expect rejection because this is small tissue when we compare all volume of cornea. Even keratoplasty patients, this is not lamellar keratoplasty. This is not very common rejection. So I wouldn't expect rejection, but there is still possibility. And I don't, now I cannot create scenario what can be complication. Irregular astigmatism, if I would see, I can manage, it is adjustable, I can rotate, or it is reversible, I can take out. Infection, all surgeries, there is infection risk. I cannot at the moment tell more. Maybe Soosan has more comment about that.
No, I agree with most of what you said, Aylin. I have also done, I have adjusted the segments, I have explanted them and then reinserted of a different thickness. So, you can really do a lot. We had one patient who actually was an eye rubber. She came back only a year later because of COVID, and we found progression. And for that patient, I decided to do a DALC instead, and I found to my very pleasant surprise that a year later I could explant it. What happens is it adheres a little bit around the edges, just like when you do a DSEC, a failed DSEC, and you want to explant that DSEC, and put in a new graft. You find that you have to struggle a little bit just to release it from the edges, but then once you've done that, it comes out easily. So it was similar. I had to just release it around the edges, and that's what took a little bit of time, not too much actually, but still a little bit, and then I could just pull it out. That was really nice to see. And I had two segments in that patient. So one I explanted because I wanted to see how easy it is to explant even a year later, and I found it was very possible. And the other one, I left it in place while I did the DALC, and again I found that I got a beautiful big bubble. Actually made no difference to the way I did the DALC, and I sent both the explanted one and the other one for histopathology, and we found that even a year later the segments were found to be completely normal tissue without any disorganization or any change in the structure. So really most of what happens is manageable. Complications, you could have progression, of course, as in any case of keratoconus, and that is something you have to look out for and continue to monitor, and of course tell the patient not to rub his eyes and all the other advice that you generally give. There are people now who've also started to do topo-guided PRK along with CAIRS in a form of bioptics. So the big advantage that they say is that when they used to do just topo-guided PRK, they would have to remove much more tissue to get the same amount of regularization. But when you do CAIRS, you've already brought down the baseline, and then the amount of TG-PRK that you have to do is much lesser, and you get better results ultimately for the patient. The advantage further when you combine it with CAIRS rather than with intacts is when you do a TG-PRK over intacts, you're thinning down the amount of stroma that's over the intacts, which leads to a further risk of extrusion of the intacts, because now you have that much less corneal tissue above it to protect it. Whereas that issue does not exist with CAIRS. So really, it's got huge amount of advantages. The question that's always asked is, does it reject? Really, it's not such a big concern at all as it's made out, or as it's thought to be rather by everybody. It's a very genuine concern, I agree, but it really is not such a big deal, because it's so different from the type of lamellar keratoplasties that you do. When you do a DALC itself, you're transplanting so much more tissue. This, volume wise, there's so much more tissue as compared to a CAIRS, but still the level of rejection in DALC itself is very low. We know that. And in CAIRS, the volume of tissue is much more lesser. It's intrastromal, secluded from everywhere else. It's far from the limbus. There are no sutures to incite neovascularization. The keratocytes get repopulated very fast from the host. And the amount of steroids I give is just 1 to 1.5 months. And that also, I don't know whether it's an overkill. I give it in the same dose that I give for phaco, post-phaco. And then we stop steroids completely. And I think really, even if it rejects, this is what I always say, even if it rejects, it doesn't matter, because it's outside the visual axis. It's outside the visual axis. It's not going to create any trouble for you. If you have an acute rejection, you could just treat it with steroids, and that's all it does. But really, that incidence of rejection is not such a big issue as it's made, because we've done a huge number of cases now, and we've really never had to consider this any big issue at all.
Mm-hmm. Thank you so much, Soosan. So we are almost out of our time limits. And tonight there were wonderful two women, very successful women, Thank you so much, Professor Cynthia Roberts, my expert, my I really thank you so much because my career is really because of you. I learned a lot of things from you. Thank you so much, Soosan. This is great innovator. And because of your idea, now we are treating keratoconus patients. Hopefully in the future, more keratoconus patients will be we'll have wonderful vision, less keratoplasty needs. So thank you for panelists, Supi, for wonderful questions, and Michael and Chris. So thank you for our efforts and timing. I wish you a wonderful day.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.